This conference will now be recorded.
Peter. Looks like the usual crew. Okay, let me run down who I see on the call. We've got an educated bunch of guys on this call today. Larry Fish, Len Sierra, Les Shelderup, Paul Frieda, Rich Jackson, Dennis Correa, Ken Anderson, Carl Foreman, Peter Kafka, and myself. Did I miss anybody? And someone just came in. Someone knows.
That was
Someone
Peter.
else just. Oh, that was Peter?
Peter's showing up twice for some reason.
Oh, okay. That's okay.
Looks
That's fine.
like Peter's in here twice.
Yeah, I
Yeah.
got somehow it got bounced out and I had to rejoin.
Oh,
Okay. All right. Well, we should be able to get rid of you.
Did you get Larry Fish?
yep.
I did.
Okay.
All right. I'll just leave you there, Peter. It doesn't matter. Okay. So let me start. Let me run down. I think I'll go from the bottom to the top today. I don't know why. It seems like a good idea. Probably because I'm a little upside down. I had a very I wasted 2 hours with United Healthcare today. They are bad. All right, Peter, is there anything you'd like to report, discuss, reveal?
Yes.
Okay. Mr. Foreman, you want to give
Hello.
us an update on your recovery?
Absolutely. I have much to say.
Oh, good. Okay. Ken Anderson, I know you have at least an update, if nothing more than that.
Yeah, I can give you guys an update for sure.
Okay. Dennis, anything for you?
Yeah, just a quick update.
Good. Okay. Rich, anything for you, sir?
I see my urologist tomorrow, and we'll see how the dust settles afterwards. Jake knows what I'll be discussing with him, but I may bring it up next week.
Do you want to talk to us about what to bring up with him? So to discuss what questions you might want to be posing him?
Sure, we can throw that out there.
Okay, I like that little wry smile as we suggest that. Okay, Paul Frieda, anything for you?
Nothing for me tonight.
Okay. Paul, are you also, well, I do want to mention, I'll mention it right now. Paul got a request from Broad Institute for his medical records. If any of you do receive a request from Broad Institute, it is related to the sample that you gave them. You gave the metastatic prostate cancer project. And if you get something from Broad Institute and they're asking for your medical records, it's associated with that. So don't just dispose of it or throw it away. It's really important for the study that they get the medical records to support the samples that they're getting. Have any of you received notes from Broad Institute? Len has.
I did.
You have not? Okay.
Did it come via email or regular mail?
I got it in regular mail because they needed my signature authorizing Sloan Kettering to release my medical records.
Okay.
And how did you get yours, Paul?
I got an email from Sloan Kettering, and they said someone has requested your records, and And then after contacting you, I realized it was associated with the Broad Institute doing the data crunching.
So you could get it either way.
Okay.
But I just want to give everybody on the call who's given a sample a heads up. They may get something from their hospital asking for their records to be released, and I encourage you to release your records to do that. Okay, Les Shelderup, anything you'd like to discuss today?
Negative.
Okay. Len, anything for you?
No, thanks, Rick. Nothing today.
And Larry Fish, anything for you?
I'm good, thanks, Rick.
Okay. Oh, we were on a roll here. The first 5 guys all had something, but the last 4 did not. Well, maybe you'll think of something as we get going. So let me see here and make sure no one else has come in whilst we've been talking. No, they haven't. All right, Peter.
Thank you for asking, but I don't have anything tonight.
Oh, Jake, I'm so sorry.
I'm
Well,
good.
I didn't, but Jake, I didn't call. Jake,
No.
I didn't call your name out before. You didn't tell me to add it.
Well, that's okay. You know, I opened the meeting, I talked to you for the first 5 minutes, and then you forget me. It's the story of my life.
Very tactful, Jay. Very tactful.
It's my first marriage. It's like my second marriage, for that matter. But no, I don't have any.
What are we on now?
All
I was
right.
hoping to get my blood results, but they didn't come in yet.
Oh, this was a redo or a follow-up?
Well, my normal monthly.
Oh, your normal monthly. Okay.
But,
Okay.
you know, I want to see if it's gone up significantly or if it's holding or whatever.
Yeah.
But I
Yeah,
guess with
yeah,
the holiday,
yeah.
everything is, you know, everything's all screwed up because of the holiday, I'm sure.
Okay. Well, next week we'll get to talk to you. All right, Peter, where are you? Still in Southern California?
Yeah, still in Southern California. Probably for another day or so.
Okay.
Yeah, all goes well. Actually, I have a couple questions for Les too, but let me start this one off on what I'm in the middle of. So, a couple of months ago, I put in a request through Dr. Turner's office with Foundation Medicine to do a genetic MSI test. It was a result of a conversation we had with Dave at our booth next to us at the PCRI conference. And that's his name, right, Dave?
David.
Yeah, David.
Yeah, David Marshak.
Yeah. Anyway, so so right after the PCRI conference, I had an appointment with Dr. Turner, and we talked about doing getting a sample from UCSF and doing an MSI test. So I called up Dr. Turner's office yesterday and to see if they got the results yet, and they said no. They heard something from Foundation Medicine about the sample not really working, something like that. Anyway, so I called up Foundation Medicine and got through to them yesterday, and it was a little confusing for me. But the gist of the conversation was that they did get something. It took a while to get something from UCSF, but the sample they sent wasn't any good to test, and they requested something from UCSF and never heard from them again. And so I talked to. I've got a call in with Dr. Turner's office. They're going to call me back this afternoon. Foundation Medicine suggested maybe I should just do a liquid biopsy test, resubmit a liquid biopsy test. But the big thing is that UCSF is not a real cooperative player. They're kind of bogged down. It gets bogged down in bureaucracy, I think, in terms of responding to foundation medicine. And I've kind of heard this from other people that, it isn't so much the doctors or the medical bureaucracy, in terms of, how quick they're responsive to other labs and sending materials out and sending test results back and this and that. And, it surprises me. But in this day and age with labor shortages and everything else, maybe it doesn't surprise me. Big organizations that kind of fall down on the job a little bit. And you have to kind of coax it through. But anyway, that's where I am. I told them I'd run up to LA and do a blood draw tomorrow if that's what's needed just to get this thing rolling.
So let me just ask a couple of questions and think about how we can address this and also broaden it out for other folks too. Usually there is cooperation. It's not great cooperation, but there is cooperation between these groups. So I'm sorry to hear that you're going through this, and we know that if you're going through it, a lot of other people are also going through it. But my first question to you, Peter, is that I'm assuming this was for a tumor sample, correct?
Correct. From yeah.
From when? That was my next question. Was it from your radical prostatectomy, or was it from some?
Yes, from the radical prostatectomy. And I talked to David Marshak, and I told him it was in 2015, and he said that should be no problem at all. That would be perfect.
Well, it's no problem. It's no problem. Well, it turned out it was a problem for them because of the samples that were sent. But the fact is that I don't know how good it is for you, because that's 3 years ago. And if it were me, I would want a much more recent sample. For example, and Ken will talk to us a little bit about this, but he and Paul Korn have been talking and speaking about using a sample that's more recent, because Ken was sequenced a year ago, and he's going to resequence now, but the tumor changes. So I don't see, when you have more advanced disease, and thank God yours isn't quite as advanced, as others that are on the call, but when you have this more advanced disease, I don't know that there's great sense in going back 3 years and what it's going to tell you, when the other way to go is to do a liquid biopsy right now. Now, the downside in the liquid biopsy is that the panel is a lot smaller, but they still test for MSI and MMR. And Felix Feng at UCSF has suggested that, at least for prostate cancer, that the liquid biopsy is going to catch most of the likely mutations that could cause you problems. So, and one thing that I've just learned recently is that while Foundation Medicine has a smaller panel, there are at least 3 mutations that are included on that smaller panel that are pertinent to prostate cancer that are not included on the Guardant panel. So, there's reason to use Foundation Medicine. But I think the big issue for me, or my big question to you is, why would you be chasing up a 3-year-old tumor sample?
Well, I spoke to David Marchek about that very issue, and he felt for the MSI test that it was no problem at all, that would be very viable and good, and a good way to do it. I mean, we spoke about liquid biopsy too, but he felt the best way to do it would be to approach UCSF for that. I mean, that's my only tumor sample. I mean, I don't.
Right, I understand, Peter, but you're missing my question. I'm not saying it isn't feasible. It's not a question of how feasible it is. It's a question of how accurate it is. And your MSI could be read off of a 3-year-old sample. That's what David was telling you.
Right.
The question, you asked him the wrong question.
Well, that's what I was looking for was the MSI. I've got
okay,
everything.
but the question to ask is the MSI going to be as accurate from 3 years ago as it would be from today? And I don't think David could answer that. He could tell you that he could easily read it, but he doesn't have the expertise in knowing how the tumors mutate over time to be able to answer that second question.
Okay, well, this is getting beyond my pay grade. I don't know. I don't know how to interpret all this stuff. But that's the only tumor sample that I had. So I'm left with a liquid biopsy, and if I need to go to LA tomorrow to give blood, I'll do that. I mean, that's why I'm hanging around.
I hear you. So
I suspect it'll go that way.
Okay, I think the bottom line is, and I'd like other people to comment on this, but the bottom line is that if you're going to be using any genetic information, you want information from the most recent sample that you can get. Now, if you don't have a recent tumor sample, you've got to trade off the accuracy of the measuring from a tumor sample versus measuring from a liquid sample. And that I can't answer. I mean, there's no problem in reading it off a 3-year-old sample, but how accurate is that 3-year-old sample versus a sample from 2018? That's the point. I mean, this isn't brain surgery. You can follow that. And that's what you got to drill down on, not whether he could get a result out of a 3-year-old sample. So
I think it would be to be able to compare the two. The 3-year-old sample and the blood sample. It'd be interesting to see, how the two.
Yes.
Okay.
Yeah.
Well, my original comment, regardless of this, my original comment is how slow UCSF seems to be in cooperating and providing information. So they're just reach and hard to get a hold of. And I don't know what's going on, whether this is a wave of the future or a sign of the future. I'm not sure. But when you start getting into genetic testing and stuff, it's something to be to address.
So did you call Geronimo?
No, I don't think it's into this. I've talked to Turner's office, and they've tried to get a hold of UCSF, and Foundation Medicine has tried to get a hold of UCSF. I don't think it's my part to get in the middle of this and try to, to fight with UCSF about this. I think if these labs and doctors' offices can't do it, then, what's my part? So I'm not about this. I'm just reporting in.
Okay, your part is the most important part, but this is really important for other people, Peter. That's why I'm pursuing it. Not just for you. It's reporting in, but it's reporting in on important information because other people are faced with the same issue. And I would disagree with you and say your part is the most important part. You're the patient. You're also a patient advocate. And if this isn't getting done and you're the beneficiary, you're the one that's got to call up and say, hey, this isn't getting done. You know, nobody's talking to each other and we can't get it done. Now, how do you do that? Well, one way is to talk to the patient navigator at UCSF. That's a good start. Another might be to talk to your doctor, but, you know, maybe you don't want to raise it to that level. But I do think that, when, you know, offices speak to offices, who knows what's said, and oh, we'll call you back, and it gets dropped. I mean, my feeling is, and if it were me, I'd be calling UCSF myself and saying, who dropped the ball here? And I've done it. I've done it on behalf of patients. And you do get stuff done. You talk to the practice manager. And you call the practice manager for GU MedOnc and you say, look, you know, this is important information. How come it's not getting done? And then they can pursue it. But I probably would start with Geronimo. But the fact is that, you know, this is why I brought up the other issue is, do you really want a 3-year-old sample? Anybody else want to contribute on that discussion?
Yeah, Peter, it's Len. I agree with Rick. You are the most important person here to request that information. They're much more likely to respond to your personal request than they are to some third-party request from a potential competitor, if that's the way they're looking at it. I don't know. But, you know, you need to call them and say, hey, look, you know, my health is on the line here. You need to get that sample over to them. And I think you're much more likely to get results that way. And regarding the 3 or 4 year results versus 2018 results from a liquid biopsy, I also agree with Rick there. It may be the same, but it may be different. And it certainly doesn't hurt to have the most recent information available.
Okay. Anybody else has anybody else on this call had difficulty getting biopsy samples from A to B or B, and I've seen this, or B back to A? That can also be a problem. Johns Hopkins are the worst. If you send something to Johns Hopkins, man, it goes into a big hole and you never find it. You can never get it back. And I've seen that happen to 2 or 3 different people. And of course, Johns Hopkins gets a lot of stuff because people send their samples to Epstein. But I know people that have gotten their samples to Epstein and then they're still waiting to get it back. I mean, you know, what's interesting to me is that that Turner didn't let you know that there was an issue, because Foundation Medicine would have communicated back to Turner. That's the right way for them to go, because it was requested through Turner. But Turner should have gone back to you ages ago and said, hey, we got a problem here.
Yeah, I don't know how they did hear from Foundation Medicine, but it was probably pretty recently. So our wires just crossed.
Okay. If you want to find out, I mean, I can give you David's number to ask some of these questions as to, you know, the accuracy of MSI from a liquid sample versus the accuracy of MSI from a tissue sample. I talked to David, as it so happens, this morning. And if you'd like, I'm happy to, you know, he knows you well enough, you can call him direct.
Right.
Or I can send him an email and ask him that question, whatever.
Yeah. I asked him that question at the PCRI conference, and he felt I could go with liquid biopsy, but as long as there was an actual tissue sample, he felt that was probably the way to go. So I suspected I'll just do a blood draw and send a liquid biopsy.
Okay. Well, I'm getting a tour of their lab on December the 12th, because they've finally I've been asking them to do this for a couple of years now, but they finally decided that they are going to create a patient advisory council. And they've gotten a group of 5 or 6 people together. And we're meeting at their lab in Cambridge, Mass on the 12th. And that's certainly a question I'll raise as to, you know, the reliability of a tissue versus a liquid sample for measurements like MSI and MMR.
Good.
Hey, yeah, it's Ken.
Go ahead, Ken.
Yeah, I just wanted to say that I think, Peter, you got a break there, because I do believe that a 3-year-old sample is going to be not useless, but without doubt, you know, getting more current information will give you better information. Paul Korn's take on it was that he wasn't, and I'll be interested to hear once you go to the lab what they have to say about percentage of accuracy between the two, because his comment was that he strongly recommended doing, you know, solid tumor biopsies for some reason. He was pushing me away from doing the liquid biopsy. He said I would have to return to MD Anderson the beginning of the year to do the biopsy to actually get new tissue. He's not able to do it this trip, which is coming up in a week. But so I have to go back there maybe January. But I'll talk more about that when I'm up. I just wanted to let you know that I'd be interested in hearing, so I can share it with him, what their comment is in regards to percentage of accuracy on the liquid biopsy for MSR, or, you know, because of his comment.
Well, what I'll do is I'll send you, because I've got it bookmarked. I can't find it right now, but I'll send you that Felix Feng paper from mid-2017, where he considers the reliability of the, what they did is they did what Jake is talking about, but they didn't do it, I don't think, for MSI or MMR. They did it for mutations. And they compared a bunch of liquid biopsies to a bunch of tissue biopsies. They did a study, and they found out, and they determined that the reliability of the liquid sample was pretty good. And I've got that. I've got the research. So what I'll do is I'll send it to you, and you can forward it on to. Tell him, you know, tell Paul you got it from me, but forward it on to him, because I don't want to muddy the waters and, you know, send it to him on your behalf or what have you. But it might be helpful for him.
I'll send it on because it'll actually save me a trip. You know, if in fact, okay. I'll send it on, because a trip to Houston's not bad, but I'd just rather not go if it's just for that.
Okay. So, sorry, Jake?
What I was talking about was I thought it would be interesting to be able to compare, you know, one individual's a tissue sample versus a 3-year-old's tissue sample versus a relatively recent blood sample to see if there's any mutations.
Oh, I see. In other words, to look at what's happened over time. Well,
correct.
I think
that's a given, Jake, because Paul would never look at a 3-year-old sample as having any value other than for comparison, because he wouldn't he wouldn't use it for anything other comparing current information with old information.
Right. I mean, I always discourage people. I don't understand. One of my good buddies recently got a 3-year-old sample or a 4-year-old sample analyzed, and I don't understand the value in it, because these cancer genes are mutating all the time.
Right.
I wish Professor Bill were on the call. He said he might be. FYI, he had his 3rd round of docetaxel yesterday, and this time he fasted for 2 days before he did the docetaxel, and he did a liquid fast. So it was a pretty rigorous fast. And he said he felt pretty groggy. I said, I'm not surprised you felt groggy. I said, you needed some food. But he said he felt great when I talked to him this morning, because I'm going to go and visit with him after I leave Boston. I'm going to go to Buffalo. And so he sounded pretty good, but he may have crashed out at this point and be taking a nap. So, but anyway, he does sound good. He's going to do 6. He was going to do 4, but now they've decided he's going to do 6 sessions of docetaxel. Sorry, that was just a quick update on Bill.
Has he lost his hair?
He says it's coming out in clumps, and his daughter, who's in cosmetology school, is either has given him or is about to give him a buzz cut, which will be interesting. Well, I mean, he looks like a 2018 Beetle. He's got the original Beetle cut still, and lots of it. Right? I think his hair's going to come back curly, and he's going to have an afro. So anyway, we'll see. But yes, I'll send you that Feng article. I think I know exactly where I've got it filed in my bookmarks, and I'll send it to you after the meeting, Ken. So anything else for Peter? I don't think you can go wrong with a liquid sample. So, which is your conclusion, but I think that it's worth raising some of these other considerations about, what you're going to get genomically sequenced. So, and by the way, on that score, there was a second pan-cancer FDA approval yesterday. So the first pan-cancer FDA approval was for MSI-MMR. So if you have a high level of MSI-MMR, no matter what cancer you have, you're eligible for Keytruda, pembrolizumab. And the second one that came out yesterday was for a mutation in, I think it's NATK or NALK, I can't remember. And if you have that mutation, you're eligible for a particular drug, no matter what cancer you have. From what I can gather, that cancer is not prevalent in prostate cancer. It is in colorectal, breast, ovarian, but it's not a mutation that appears much in prostate cancer, so it doesn't really affect the prostate cancer men. But it's just interesting the way the FDA is going, and within the context of precision medicine, we're seeing more of these pan-cancer approvals. And I said to David, well, aren't there 3? What about BRCA? And he said, well, no, because BRCA is still being approved only on cancer by cancer basis. So it's been approved for breast, it's been approved for ovarian. I don't know if it's actually been FDA approved for prostate. I'm not certain. Do you know, Len, if PARP inhibitors have been FDA approved for
No, not for prostate.
No, but anybody who's BRCA positive with prostate cancer has not had a problem in getting their insurance companies to approve it.
What's that term you use, Rick? Pan cancer? PAN?
Yeah.
What does the pan mean?
Pan means across everything.
Oh.
Like panoramic or,
Right. Okay, that makes sense.
Or pantechnion. How about pantechnion? Look that one up.
Oh, geez.
Now, the The trade name for the drug they approved is Vitrakvi, an unusual name, Vitrakvi.
Mm-hmm. Mm-hmm.
It looks like, just judging by the generic name, it looks more like a kinase inhibitor rather than monoclonal antibody, which is what the immunotherapy drugs usually are.
It doesn't have to be an immunotherapy drug. It could be just a drug that acts on this mutation. It may not act in an immunotherapy fashion. I don't know. But I think the bigger point is this idea that it's a precision medicine drug. In other words, if you've got a mutation, then you should be taking a certain drug, rather than if you've got a cancer, you should be taking a certain drug.
Right.
But once again, we determined that this particular drug that just came out is not one that's going to be applied towards prostate cancer, correct? We're just talking
Correct.
about.
Yeah, we're just talking about the fact that that there's a move. It's this precision medicine move where they're approving drugs based on certain features that you have, certain well, features is the wrong word, certain pathological indicators that you have, like a high MSI or a mutation in NALK. Or to some extent, it's a little bit different because it didn't get a pan-cancer approval, but to some extent, having a BRCA mutation or a mutation in the BRCA pathway.
It's called NTRK, neurotrophic receptor tyrosine kinase, gene fusions.
Okay, and what's the mutation? Is it NALK? Is that what it's called?
NTRK.
Oh, NTRK, okay.
Neurotrophic receptor tyrosine kinase gene fusion.
Okay.
Fusion.
It's a fusion. Yeah, that's right. David explained it to me. It's a gene that tends to fuse with another gene to promote the growth of the cancer.
Right.
So, this acts on a certain, it doesn't act on a mutation, it acts on an actual gene. Sorry. But the concept's no different. Questions, anyone? You're a silent bunch. Come on. Okay.
Okay.
All right. Yes.
Hello, guys. So I don't know. When I was reading, I didn't read very carefully when I was reading about this new precision medicine, this new approach you're talking about, from the London study that they announced a few days ago from the London research, that I thought that it was the DNA of the mutation itself that they were attacking. That they were stopping the cancer cells from replicating by attacking based on the profile, for the DNA profile of the mutation. That's what it sounded like. Maybe I didn't really pay that much attention because didn't mention prostate specific.
You're talking about this this NTRK, Larry? Are you talking about this NTRK,
didn't write
Larry?
it down or anything. I thought it was this. I thought it was this thing that you're talking, what you're talking about right now, but maybe not. Maybe it was something else. But it just came out, like the announcement just was 2 days ago.
Yeah. And what is your point?
Well, I didn't think it was your genetic mutation, like the genetic mutation of the DNA of the individual from your but more or less a somatic mutation. The mutation of the cancer mutated into this.
Well,
The
but
cancer.
I think the point is this, and correct me if I'm wrong, certainly Len, if you have this NTRK gene, then you are eligible for this new medicine. Because the NTRK gene, when it shows up, is a gene that fuses with other genes and can cause cancer. So you have to be tested to see if you have this NTRK gene, just like Peter has to be tested to see what his level of microsatellite instability is to see if he's eligible for pembrolizumab.
Well, I see your point. Is it the same thing? I mean, as a is a somatic biopsy the same? It's not. It's the mutation that it talked about. First of all, it was like for late stage. It was useful in late stage cancer, and they talked about it didn't matter whether the cancer was breast cancer or they mentioned a few. I don't know if they mentioned bladder, but they mentioned a few cancers, and that it was about. I thought it was about attacking the DNA of the mutation of the cell that the cancer produced.
Okay, but it doesn't matter how
Right.
I mean, we're not interested how the drug works. The point here is that if you have that mutation, excuse me, if you have that gene, it isn't a mutation. If you exhibit that gene, you're eligible for that drug.
Yeah, I think that's probably, but in terms of like the precision medicine, it's the idea that they're slowly going to start cataloging all the mutations that your cancer cells can go through.
And not necessarily mutations.
Not necessarily mutations.
Not
You're
only
talking about
mutations. There may be other things. They may be genes, like in this case, or they may be other measures like microsatellite instability and mismatch repair. That's the point I'm trying to make here about precision medicine, that we are looking for certain pathological features that make you eligible for a certain drug. That's what precision medicine is.
Yeah, I mean, I understand it's towards that individualized medicine where they're going to type the various mutations or whatever you want to say, the various characteristics of your cancer and then be able to attack them precisely.
Exactly. That's what precision medicine is. So that it doesn't have to be just a mutation. It's a feature of your cancer. And we have a medicine to address that feature.
Right, and this was the second, as you say, like, because of pan-cancer medicine.
Yes, yes, yes. I mean, in my mind, really the third. It is exciting. In my mind, it's really the third because I still, even though I realize that that the BRCA mutations have not been another pan-cancer, the reality is that the insurance companies and the medical community are using, if they see this mutation, they're using the same drug. So in effect, it's happening, and it's really significant to me that the insurance companies have poured off on that. They're not fighting it. I mean, I recall back in 2015 when Dominic, God rest his soul, found out that he was either BRCA positive or had a mutation in the BRCA pathway. It didn't take him, it took no more than a couple of weeks for him to convince his insurance company that he should be eligible for a PARP inhibitor. Anyway, let's and Mike Stewart, I see that you've joined. Welcome, and we will make some time to for you to discuss your issues. Mike's been on the call before. He was in touch with me during the week, and I said to him to try and be sure to get together with us. So we'll get to you. Carl, tell us briefly how you're doing and what's going on.
Okay, so just to recap, I had my robotic surgery on November 14th at the Cancer Institute of New Jersey. Went home, including the catheter, within 24 hours being released from the hospital. Catheter was removed the day before Thanksgiving. And then it became quite interesting to just deal with everything overall. It wasn't the easiest of Thanksgivings to share, but it's great to be with family. And within a day or two after Thanksgiving and after the catheter was removed, I started having some leakage from one of the incision sites. There's, I think, 6 in total from the robotic surgery. And I hadn't been told in advance that this might happen, that there will be some leaking. The incisions are not closed off by any not incisions, but whatever. It's like some kind of surgical glue that is used to cover up the incisions. So over time, as I've been taking showers, and they're supposed to start deteriorating, but this one particular site, it was like gushing out this relatively clear liquid, and using various gauzes and trying to be as it caused immobility. I was afraid to leave the house because I was leaking. It was going down my leg, and just to find the right thing to control it. And I had to be careful not to put a Band-Aid over it to like pull it off altogether. So I contacted the surgeon over the weekend, texted him on his cell phone and told him what was happening. And he said to me, "Well, are you peeing normally?" And I said yes. He said, "Well, okay, that's a good sign. So the leaking is normal." Okay, so I said, "Well, how long can it occur?" "Well, we have no idea. It could be weeks, it could be days." Bottom line is that the leaking actually stopped about 2 days ago, thank goodness, and things are getting to a bit of normalcy now. Every day I feel like I'm getting stronger. I'm able to walk more. I have to keep reminding myself that I have to drink a lot more than I have in the past, and I have to move around a lot more to make sure that I walk every once in a while. So that's what's happening on that side. And so every day it's getting better. Also, just to talk about my pathology report, I figured that would be of interest. And the report, the surgeon was mentioning some kind of codes, and I'm not sure that I have all of them, but for the primary tumor, it says PT3B, and then for lymph nodes, PN1. They took out 27 lymph nodes, and 2 were positive. And he said overall he was it was better than expected, the results that the surgeon had expected. So also the seminal vesicle had some intrusion as well, and the size of the prostate was, it says the weight was 62 grams. I'm not sure if that's, I would expect that's relatively large, but and there were a total of 12 samples that were used for the pathology report. It also says here, greatest dimension in millimeters of the tumor, 35 millimeters. That sounds a little bit large to me. But so that's it. I mean, overall, from the surgeon, as I said, he said he was pleasantly surprised because of my advanced prostate cancer stage being determined metastatic, and as I spoke previously, that I also do have the BRCA2 gene, so I'm still following up with that. I do have an appointment with Dr. Dumchek at the University of Pennsylvania. That's in a couple of weeks to speak with her. My next appointment with my oncologist is December 4th. Oh, interesting enough, too, they did do a PSA test 5 days after surgery. And the result was there was a slight increase from the previous PSA test, which was done, I think, a week or two before the surgery. So before the surgery, it was down to 0.12 or 3. And then 5 days after surgery, it was 0.15. I did speak to my oncologist nurse about it, and she said that's not at all unusual that soon after surgery there might be a little bit of a blip. But as time will tell, the PSA is anticipated to continue to go down to virtually 0 now that the prostate is out, and I continue on the Zytiga and prednisone and Eligard and Xgeva. So
there's a couple of things here that I would like to just check with you. You left out the most important piece of information for most of us, or I wouldn't say the most important, but a very significant piece of information for most of us on your post-pathology biopsy. Your
post-surgery
pathology, excuse me. What was your Gleason? What was your Gleason score?
Let's see if that's in here.
It certainly should be.
Gleason pattern cannot be assessed. It all says it cannot be assessed. Oh, also the margins, by the way, versus positive versus negative margins. So the margins were clear and negative, so that's a good thing.
Okay, so clear margins is really important. I would want to know, I would be following up to find out why the Gleasons cannot be assessed. That does not make sense to me. They've got the whole prostate there. Why can't they assess your Gleason? I've never ever heard that before. See, what we want to know, what we like to know is how does your actual Gleason, true Gleason, compare with the biopsy?
Okay.
And we know that you were a G7 changed to a G8.
No, well, I was a 7-8, and then it was changed from Dr. Epstein to a 9-10.
Well, wait a minute. There's no 9-10. I mean, you're either a 9 or you're a 9 or you're a 10. So 4 plus 5 or 5 plus 5.
Okay.
So were you? I mean, I don't know how. I had thought. Yeah, I see it here. I mean, just check your thing. So Hopkins, he would have given you one number. Either you were a 4 plus 5 or a 5 plus 5. He may have given you a tertiary number too. So he could have.
No, I do believe he gave a 5 plus 5, but it depended on which sample, like 1 or 2 or a 5.5. Another one was a 5 plus 4.
Okay. So then you're a 5 plus 5. It's always the worst one.
Rick, I'm thinking they may have told him the Gleason couldn't be determined post-surgically because he was on hormone therapy. And sometimes they say that the hormone therapy will distort the cell morphology.
Yeah, but I hear you. But he'd been. How long had you been on? How long had you been on hormone therapy when you had the surgery?
I started at the end of June with a 30-day Firmagon shot, and then went on to Eligard and Zytiga a month after that.
Yeah, I think Len's right, but I would certainly pursue it.
And I think I do recall the surgeon saying the same thing as Len was saying, because of having been on that therapy for 4 months.
Yeah, if it's 4 months, it's possible that it may have that might well be. Thanks. That's a really good point. Yeah.
Actually, I am looking here. It does say something. Hormonotherapy effect present. If that's related, I'm not sure.
Yes. Because so in other words, they're able to see. I don't know how they see it. That you're taking hormone therapy.
Right.
Right. Okay. So that thanks. That's good. Yeah. So just to clarify, 62 grams, which is the same as cubic centimeters, is large or large-ish. And your normal level of PSA would be around 6. That's what a 60. That's just the amount of PSA that a 60-gram prostate makes. So the fact that yours was lower means you don't produce a lot of PSA. What did you say your PSA was right before the surgery?
20.
20. Okay. And 3.35 millimeters is significant, but it's not that big. I mean, it's not a lot of for somebody with your diagnosis, it's not a lot of tumor.
Okay.
I think I had 4 centimeters, which would have been 40 millimeters. But so, and the T3B means that it's in your seminal vesicles, which you know.
Right.
The only thing that the only other thing that puzzles me is we knew that you were metastatic.
Right.
Where were the metastatic? It was in the bone, right?
Yes, pelvic bone.
So how can you be T3B? You can't be T3B. You have to be T4, right, Len?
Yeah, T4.
T3B means that you have local metastasis. You have seminal vesicle invasion, and possibly some lymphatic invasion. It depends. You're N1, so you have lymphatic invasion. But T3B is not right. You're T4.
Well,
I mean, unless the pathologist is, and this is something you should clarify with Kim, unless the pathologist doesn't see the rest of your medical records, so he doesn't know that you have bone metastasis. Okay. But it's kind of, what do you make of that, Peter or Len?
Well, I was labeled T4 by MSK just because I had seminal vesicle and lymph node involvement.
Yeah.
Without bone. So I think it's T4. I guess it doesn't matter.
No, I mean, you're treated like you're being treated as if you're T4 anyway, but it's kind of a strange post-pathology report. It's almost like it's been done in a vacuum.
Carl,
yeah.
This is Peter. I was wondering, did they remove your seminal vesicles, or they just noted that there was involvement there and left them?
It was removed.
Oh, it was removed. Okay.
along with 27 lymph nodes.
Right.
Yeah, but of which only 2 showed up positive, which is also kind of interesting when you have COVID bone mets.
Yeah, it also says the size of the largest metastatic deposit in millimeters for the lymph nodes is 18 millimeters.
Well, that's
small.
1.8, almost 2 centimeters in the lymph nodes is decent size.
Yeah.
In the lymph nodes. But anyway, look, the point is this, you know, I don't know why they put you at, they staged you at T3B, because sadly you're T4, you know, M1, you're T4, M1, N1. And you can ask Kim about that, but as Len says, it doesn't really matter. It only matters to the extent that if you wanted to do a trial, you know, it might cause a little issue that you'd have to clarify with them.
Right. Well, clearly I'm already in the trial. I'm in the SimCap trial.
Yeah, but you know, in the SimCap trials, you should be considered T4 and not T3B. So anyway, well, listen, we're glad that you're we're glad that you're healing up. We're glad that this leakage problem is over. Anybody else want to say anything to Carl?
Carl, have you had any radiation to the metastasis, or this is your first treatment?
Well, I mean, first treatment in addition to the hormone therapy, no radiation.
Okay. Did they talk to you? I mean,
No.
who is, you're on a trial, I guess, huh? So, I mean,
Yes.
who's following up with you in case you need to go to radiation at some point?
Well, I'm at the Cancer Institute of New Jersey. The head of the trial, Dr. Kim, is the surgical oncologist who did the surgery on me. And the medical oncologist I'm with is also at the institute. And my backup oncologist, so to speak, is Dr. Mark Stein out of Presbyterian.
Good. Okay.
Okay. You know, Peter, it's sort of a strange situation because it's more of an issue to see whether debulking makes a difference. I mean, that's the thrust of the trial.
Right.
So would they do salvage would they do adjuvant radiation when he has bone mets? Probably not. So anyway.
Right, and I know we had talked briefly to the extent that I am BRCA2 positive, that radiation is not really a viable option.
Yeah, that's a good point too. That's a very good point. Because the radiation is likely to have more significant side effects because of the mismatch repair. But anyway, it'll be interesting to see what Domchuk says about your about what trials might be available or what treatment you might want to do for given your BRCA positive. By the way, I just saw that Abramson Cancer Center just became an NCCN hospital this week, which is significant because the BRCA Center, what's the name of that BRCA Center?
Oh, yeah, it's got a long name. I don't recall.
It's named after somebody, Held BRCA Center or something like that. But that BRCA Center is part of Abramson.
Yes.
So, and Abramson joined the other 27 or 26 NCCN hospitals this week. Okay, Ken.
Yep, that's fair enough. You know, I can appreciate all the conversation. I really do appreciate getting everyone's kind of take on where they're at and what they're up to, because I'm like 18, 20 months into this, and the original first line, you know, Lupron drug has failed me, I guess. So I've had 3 consecutive PSA rises. Well, they've been small rises, they've been rises. Right now my PSA is at 0.95. It was up from July. My low in July was 0.4. So it's gone up the last 3 months. I scheduled for my local med-onc to start Zytiga. And to answer your question, Rick, Paul's take on Zytiga versus enzalutamide is Zytiga is what they pretty much go with first. So that was his reply. Even though it requires, that's what I'm going to do. I do go to MD Anderson on the 5th, 6th, and 7th for scans and just kind of a general sit down and to see. He's not anticipating, I don't think, any change in my scans, because he said that PSA is still relatively low. It's caught so early that most likely not going to be much change, that it's caught so early. Interested in seeing him just the same. And that's pretty much it. You know, and I'm going on the next, like the second line drug, and I don't know, that is pretty much it for me at the moment.
Some of you on this call have seen your PSA rise after chemo and then started Zytiga or added it to your LHRH drug, and you've had good results. Isn't that the case?
Yes.
I was just checking to see if you were awake, Dennis.
I'm paying attention.
Okay. Would you like to share your results or your history with Ken to give him some encouragement?
Yeah, I had very similar situation. You know, the chemo with Firmagon to start, switched to Lupron, and after 1 year, it started. My PSA started rising.
Oh, you had chemo.
And yeah, that was after the chemo. About 1 year after the chemo, and being on the Lupron, it started going up. And the doc that I had at the time told me, "Don't worry, you're doing fine." And I just couldn't accept that information, and went up again the next month. And so finally, I went and found another doc, and he said, "Yeah, this is a progression." And he did some scans, and sure enough, found that I had 2 more metastasis, one in my left femur and one in the pelvic bone, in addition to the 6 that I already had. I believe it was 5 in my lumbar spine and 1 in my right femur. So anyhow, the recommendation was the Zytiga, and that worked extremely well for me, and has currently brought me back down to less than 0.1. So, and I mean, it's just, you know, it might intensify the side effects that I was having from the Lupron a little bit, maybe a little more hot flashes, or that type of thing, a little more fatigue. But other than that, I'm pretty happy with the results.
So it can happen, Mr. Anderson.
No, I understand. I'm actually anticipating to drop pretty low, because Paul informed me that and he said, and maybe I should have, he said, you know, 8-9 months ago, because something had changed. I'm not sure what had changed, because I didn't really look it up, but he said that I could start Zytiga anytime I wanted to. You know, he said I could double up on Zytiga and Lupron at the same time. And he said once I get on Zytiga, my PSA is going to go to the bottom. So my T levels. My T levels actually have been bouncing around testosterone levels. They've been bouncing around, you know, up a couple points, down a couple points. I have no idea why, but and it could be a cycle. You know, 3 months of Lupron. At the end of the 3 months, it's not as effective as in the beginning.
And so how long, Dennis, how long have you been on Zytiga now?
14 months.
14 months, okay. Because Ken and I had some discussions about, you know, how long some of these drugs can last. And you know, I think, you know, 14 months is great. I mean, I think most people, if they get 8 or 9 months, they feel good about it, and 14 months is great. And some people get more, and, you know, Rob, God bless him, got 4.5 years. So, so there, you know, it's a good way to manage. It's a good way to manage. Anybody else like to talk to Ken about his diagnosis, decisions, where he is, what he's going to do next?
Or anything that I might talk to Paul about when I go visit him in a week.
Oh, yeah.
Ken, this is Len. You said you're going to have scans at MD Anderson in the first week in December?
Actually, the 6th, I have the scans. The 7th, I meet with him.
So what type of scanning?
It's a PET scan. I believe it's called a PET scan, PET scan.
Right. But is it, you know, if it's gallium, PSMA, or?
PSMA.
Yeah, okay. And have they already put you on Zytiga?
No, actually, my local med-onc here is hesitant, but I'm kind of pushing her to put me on it as soon as possible. I'm not giving her the out. She wanted to wait until after the scans. I'm not sure why.
Yeah, because it'll be easier to pick up the lesions on the scans before they put you on hormonal therapy, which will reduce your PSA, and they may not pick up.
Take her advice, not be such a jerk.
What?
Maybe I should take her advice then and not be such a jerk.
Oh, well, yeah. I mean, it's not a case of being a jerk, but you know, what's the point of doing the scan if you're going to knock your PSA down so low that it's going to be undetectable?
Now that you're telling me it, I understand. I don't know why she couldn't have just told me.
Yeah, Ken, this is Dennis again, and my doc did the same thing. I did the Oxman scans, and there was a result of that where they determined the additional metastases that I had, and then the suggestion for the Zytiga came after that.
All right, so I'll wait until after my turn to go on the Zytiga.
Okay.
To be having it climbing up, I'd like to get it, you know, batted down again with whatever I can. But I'll wait because it sounds like there's a benefit. Paul didn't mention anything about it, and he said I should go on it as soon as possible, but maybe he didn't realize that I was to go on it, you know, like today. So, anyway.
Yeah, if you wait a week or so, it's not going to make a big difference.
I know. Actually, I originally was thinking wait till I got to some manageable in my head number, and I put the question to Paul, and he didn't think it was a good idea. I was thinking maybe if I only climbed 10th of a month, but maybe I could wait, you know, a year and it'd be 14, and then I could go on it. But he didn't think that was a good idea.
Did you say your PSA was 0.9 now?
0.95, yeah.
That's the ideal place for a gallium-68 PSMA PET-CT. It's very effective around 1. So I think you're wise waiting start the Zytiga later on after the test.
Gotcha. That's what I'll do then. Thank you very much.
Okay. If there's no one else that would like to say anything to Ken, we will move on to Dennis.
Well, I'd probably let the cat out of the bag already. I just had my blood work results today. I got from my portal, online portal, and I am still being reported for the PSA at less than 0.1, which is continued good news. And also coincidentally today, I had my annual physical with my GP, and which I've been doing right along here anyway. And he's had my PSA on his scan, so I just let him continue to do it. And with great results, his lab came back at 0.0. So that kind of reinforced, when you're going along and you're getting the same number time, months after months after months, you start saying, I wonder if this lab is really doing a good job here. And so when I get this from a second lab at 0.0, that kind of relieved my mind a little bit, which is, this time when maybe like 3 or 4 days before I'm due for my blood work or my visit with my doc, I start getting a little anxious about what the number's going to look like. And fortunately, this one came back very good. The other thing that I don't know why it happened, but with my GP's report, my cholesterol has dropped from, the total was 232 last year, and this year it's 184.
Okay.
Which is below the reference number. The triglycerides are down also. So everything was down, and I'm just wondering, I haven't really done anything a whole lot different. My diet is pretty close to being what it was before for this past year. My exercise levels are about the same, maybe a little bit less.
So
I don't know if it's a side effect or.
I have a couple of questions for you, Dennis. Are you taking the same statin that you were taking last year as this year?
I am not on statins. Not last year. It was probably close to a little 3 years ago when I was on simvastatin, and I stopped it because of muscle aches and pains. Which we thought maybe, and my doc agreed with it because my good cholesterol, the ratio was so much higher. I had really good cholesterol, so the ratio was still within 2.5 to 5 or something like that, 3.2 to 5, I guess. So he said that's okay. You probably don't need the statins, and coincidentally, that was the time when my PSA also took a jump. When I stopped the statin.
I think, and we talked about this just recently, so we won't get into it again today, but we talked about it within the last 4 weeks on one of the calls. But SAM, if you look for the reference SAM, S-A-M, you can re-listen to that call. There's good reason for people with metastatic prostate cancer to be taking statins, because even though your ratio is good, the less cholesterol you have, the better you are. And 184 is terrific. Is your ratio about the same this year as last year?
It's about, last year was 3.6. This year is 3.2.
Okay, so it's there and thereabouts. But I mean, you might try rosuvastatin, which is a little different to simvastatin, and we just try it on a low dose. See if it gives you cramps, you stop it. But I take rosuvastatin now, and I don't think it has anything to do with the cramping. My cramping hasn't gotten better or worse, but it's just a good thing to do for, as some of the guys on the call will tell you, it's a good thing to do. The statin, aspirin, metformin trifecta.
Just to make a comment here, Rick. I saw something today on a small study in Europe where the people that are on metformin should have their B12 checked periodically.
Yeah.
Because that can, it doesn't happen to a lot of people, but it does happen to some, and it can lead to peripheral neuropathy. So,
you know,
just a word of caution.
Yeah,
I had a comment about that too, Rick. I started statin. You know, it was 2.5 years ago. Atorvastatin, Lipitor, generic, and it was only on 10 milligrams. And he wanted me on 20. I cut it down to 10. On the 8th day, had neuropathy of my feet. And then I developed, and I threw them out, but it was out of the barn, and then I had fasciculations of my lower legs. That's, you know, little muscle tremors under the skin. Then I developed chronic fatigue, and I had chronic fatigue syndrome for about 2 years, and I was just ill all the time, and I couldn't exercise because of the fatigue. So I just mean, what I'm trying to say is that statins for some people can be extremely dangerous. They can be progressive. It's, in my view, and I've done a lot of research on it too, I think it's one of the most dangerous drugs as far as benefit, you know, versus, you know, the risk that you can take. But that's my take on it. And some people, it's just very light, the symptoms, and you can develop dementia from it, you know, diabetes. I mean, it's systemic. It can be hideous stuff. Is what I've read a lot about. So it's just cautionary note.
Yeah, in my general philosophy, Rick, is, you know, if there's a drug out there that I don't have to take, I don't want to add it to my regimen of stuff I'm already taking. Both my GP says, you know, from the standpoint of where you are with your cholesterol, your heart is in good shape. You're not having any issues there. And then my med-onc is also, Dr. Singh has not been crazy about it. He's not advocating it for me. So if things start turning the other way, then yeah, I'll start throwing more stuff at this thing.
Okay, I want to come back to David because, you know, with the greatest respect, I mean, I would suggest that 8 days of statins is unlikely to have the sort of permanent effect that you had. Something else must be going on there. I mean, I can see it if you're on statins for several months. And the fact is that now, if you talk to most GPs, they'll tell you that everybody should be on statins. Now, I'm not saying that they don't affect some people badly, and certainly muscle cramps is one. You know, I would ask you to show me where you've seen that statins cause dementia. Again, I'm not saying they don't, but I'd like to see that beyond anecdotal correlations. And I mean, 8 days, it'd be tough to make that one stick with me, and I think with most doctors. But
Well, we'll have to probably disagree on that, Rick. But I'll send you some information on that, some links and everything.
No, I don't want links. What I want are the studies.
Well, that's what I mean.
What I'm asking for here's what I'm asking for: peer-reviewed studies that show the causation. Peer-reviewed studies, because I'm not going to go through a whole bunch of stuff and seek it out myself. I would challenge you to show me that 7 or 8 days of statins can cause long-term effects like neuropathy. I suffer from neuropathy, so I know how bad it is. And it's just started up again with the cold weather. And it was a result of 28 months of hormone therapy. And we know it's associated with hormone therapy, but it's not frequent. I'm fortunate enough, I've been taking statins since I was in my 30s, because I have a high family risk, and I had a very smart GP at the time who happens to be still a close buddy here, not my GP, who put me on statins. But I would challenge you or anybody else to show me that 8 days of statins can cause neuropathy, chronic fatigue, and whatever else. I'm not saying you don't have that, but I think to correlate them with 8 days of statins, I'm bringing this out because I don't want to scare people listening to this call off statins. Yes, we know statins have side effects, but I would like to see good peer-reviewed evidence. Len, do you want to comment on 8 days of statins causing long-term neuropathy, chronic fatigue? What else?
Yeah, I'm with you on this, Rick. It's highly unlikely that such a short regimen of statins could cause such side effects. And I'd like to see documentation, studies that verify that. But
I'm happy to know they cause cramps because I wasn't sure why I was getting cramps. I've been taking the statin and metformin for the last 2 months.
Yeah.
And in the morning, I get real bad cramps before I get up in the lower part of my legs. And it's like, I was not expecting the reason for the cramp. I thought it was because I was exercising more. So
no, they do cause cramps.
Yeah,
And wait a minute, Dennis, what is the cramp solution?
TheraWorks. TheraWerks, I believe it is.
No. The best thing for cramps, the University of Washington, the football players take a teaspoon of yellow mustard.
Yeah, I heard that too. The TheraWorks is TheraWorks. TheraWorks relief, muscle cramp, spasm relief. And this stuff works both as a preventative. When you know there's going to be a special time where your cramp comes on, you put this on beforehand, it'll prevent it. If you get a cramp and you put it on right away within a minute or so, the cramp is relieved instead of getting to a real strong. This is how it's worked for me. So that's all I could say. And if sometimes after a cramp you have a muscle pain, that the cramp was so severe that your muscle actually hurts, and apply this and that pain goes away. And this stuff is non-prescription. It's Walgreens, CVS has it. The other thing I tried is tonic water when I'm having a cramp, and that has worked for me also. It's a sort of has some kind of a neurological effect with neurons in your mouth, whatever, it works through your brain and then it relieves the cramp. And son of a gun, the stuff works. But what I'm finding is most of the time I do get the cramp, it is after exercise and either, failing to do some stretching, or, warm up or whatever. But the big thing is hydration. If I don't do enough electrolytes, Gatorade, stuff like that, I will get those cramps. And I had a severe case of it a few weeks back, and I didn't realize what it was. And I said, son of a gun, I've been out here doing all this stuff and I'm perspiring. it wasn't my usual exercise, but it was just being on my feet a lot and doing some stuff. And I was getting cramps every place. So I ran into the bar and I said, "Give me a thing of tonic water." I start sipping it. Son of a gun, the stuff just went away.
Right. Well, anyway, so there's a couple of solutions for you. And Rich Jackson, who we're going to come to next, so has suggested pickle water. Isn't that right, Rich? Rich, am I wrong? Wasn't that you that suggested pickle water?
Well,
Pickle
actually,
juice?
pickle juice.
Pickle juice, right. Pickle juice.
That one, it may be anecdotal, but it's personally observed anecdotal.
Right. Well, you know, I've had cramps going back to when I was a teenager after exercise, so I don't necessarily associate it with my statin use, but I do know that it is associated with statin use. So anyway, let's move on to you. Just give us a quick update of your disease, Rich, and then, you know, we can talk about if there's anything special to focus on when you're with your doc tomorrow.
The initial diagnosis was Gleason 9, five of the 6 cores with an 8 on the 6th core. Did combination therapy, high dose, 25 IMRT, and just finishing up 12 months of ADT. Bumped into several studies that indicate that for combination treatment for high dose or for high Gleason, 8 to 10 months is sufficient. 12 is ideal, or even perhaps a bit overkill. There's not a lot of studies out there that deal with 9s in combination therapy. The knee-jerk answer on ADT is 18 months. We don't care, 18 months. The end of my 12 months will be the 29th. Tomorrow's the 28th. And I'll talk to the oncologist tomorrow, and I'm pretty sure he's going to push for 18. And I'm pushing back for 12. Quality of life and side effects.
I can only talk about my own experience here and some stuff that I've heard recently. And I had combination treatment, but with low dose and not high dose. And I did 28 months. And for the longest time now, I've been saying that, I mean, there was a study that said, I think that came out recently that compared 12 months and 36 months and said there wasn't a lot of difference. So people started saying, well, you know, then let's just do 12 months. And then there was another study that had 18 months versus something. And just recently, my doc, who's pretty well recognized internationally and speaks a lot, was consulted by one of the guys that's on this call, Jay Mills, and he is still very firmly in the 24 to 28 month camp. He still thinks 18 months is too short. He feels that 18-month study was underpowered, just didn't have enough people in it. And, you know, he's certainly not happy with 12 months. My own anecdotal experience, and it's totally anecdotal, is that people that stop too soon, the disease comes back. And so if it were me personally, I would not do less than 18, personally. And if I could hang out beyond the 18, I'd do it. But yes, there's no question that it's at a cost of quality of life, and that the quality of life gets worse and the side effects get worse the longer you stick with it. But in the long run, I've had durable remission out of it. And so that's my 2 cents, Rich, but I think I've told you that before.
I was aware of your feelings on the subject.
Anyone else have any thoughts on that?
Yeah, I'd go with 18. Rich. I mean, I understand why you want to stop at 12, but I thought that most studies showed that 18 was superior to 12. There's here are the ETs from the prostate cancer conference out in LA. I just got today. Mac Roach is on there. He's Rick's doctor. You can listen to his lecture. I don't know if it'll influence you or not, but it's a tough call. I understand how you feel, but I do think that another 6 months would do you well.
It's a crapshoot. Straight up, any way you look at it, it's a crapshoot.
That's true.
18 months may provide additional benefits that 12 don't. And 12 may provide enough to accomplish what's necessary for what I've got. And that's the thing, it's a trade. The doctor tomorrow cannot guarantee me anything, including that I'll wake up Thursday morning. At the same time, I can't guarantee him I'll wake up Thursday morning either.
All right.
But
look, nobody can argue with you, but we love you, and we don't want to see you wrestling with this disease for the rest of your life if you don't have to. I mean, that's the bottom line. And to me, I don't call it a crapshoot, because I think that there's enough evidence out there with quality studies that the longer you are willing to do, the better you are. We as individuals don't want to do that, don't want to do it because it makes our life miserable. So we can rationalize every which way why we shouldn't do it. But those who have stayed on hormone therapy for longer have gotten better results. And there's evidence out there. So, I was frankly very surprised. I mean, 12 months to me is too short. I was very, very surprised that Mac was still insisting on 24 to 28 months. But he just feels that 18-month study that everybody's gone to now was just a bad study. We'll only know over time.
well, that's the Ascend and the Stampede study that went to 18 months. NIH indicates that at 36, there's 22% of the men remain castrate forever, period. 50%, 52 to 54% of men reach 50, which is super castrate, barely. There's 18, they did 18 compared to 36.
Yeah.
And indicated that 18 was as good as 36.
Right. That's the study that study is the one that he considers underpowered. I think it was only about 300 men.
That was either the Ascend or the Stampede study.
No, it's not. Stampede's a much bigger trial. I think Stampede is a much bigger trial because Stampede has all the different arms in it.
Okay.
I think, I mean, again, I have it, I can look later, but I think that 18 versus 36 was a smaller study, and that's the one they consider to be underpowered. That's the one Matt considers to be underpowered. But
What would be the harm
and then
of Rich? What would be the harm of Rich just stopping it for a while and watching his PSA? And if it starts rising again, then jump back onto the ADT. What would be the harm in that?
because then he's going to be on and off his ADT for the rest of his life. Whereas if he does a little longer now, there's a possibility he may never have to go back on it.
With a 9, that is extremely unlikely.
He doesn't want to see his ADT. What was your original diagnosis? Gleason 9 and
PSA of around 13 or 14, something like
right.
that.
But there was no evidence of metastasis, right?
CT scan, bone scan came back negative.
Right.
Possible ECE, but
right. So to answer Jake's question, if his PSA starts to rise, then this has failed. The success from what Rich has done would leave would mean that he never has to go back on ADT, and that's the possibility that's still out there for him. Doesn't mean he's cured, but it means he's got durable remission. That's my situation.
Rich, this is Peter.
Yes. Hi, Peter.
Yeah, I was diagnosed pretty much the same as you a number of years ago. And, I'm not going to give you advice or this or that. My experience, this is my third round on ADT. And this round, I'm at the 10-month level now, 10-month mark on Lupron and Zytiga, and I'm really tolerating it very well. I mean, I to this round thinking the worst. I think, oh shit, I've got to go back on ADT. It's going to be terrible. But this time yes, it has. I mean, it's doing its thing, but it's kind of a breeze. The first time I was on, the second time I was on, yeah, it was the pit, and it scared the hell out of me. But for some reason, this round, so I'm just letting you know that if by any chance it comes around again, in your future, don't be freaked out. Sometimes you can tolerate it well, and it'll still do its job.
Okay. That's good to know. With a 9, I don't expect a durable remission. I don't anticipate not doing something in 3 to 5 years.
Okay.
What I've read, what I've seen, what I've heard, it can happen, but you bet with the house, and the house wins. So I suspect that I'm going to come off, I'm going to have another 3 to 4 months of less than 3 testosterone and less than 0.1 PSA. After that, that'll get me out to 15 months. If my testosterone stays at less than 3, that'll get me out to 15 months. So actually, if I stayed for 18, then I'm looking at 20 to 24 months total before I start picking up recovery. But at the moment, I don't see twiddling my thumbs in 10 years saying, hey, everything worked. Whether I do 12 or 18 or 24, the only thing I see is that I will be that much more miserable that much sooner.
Yeah, I mean,
there's no right answer.
No, there's no right answer. I mean, I was Gleason 8. I wasn't Gleason 9. And there's a big difference. between being Gleason 8 and being Gleason 9. So I certainly accept that. If you're looking at it as being on intermittent hormone therapy for the rest of your life, I would say, okay, you know, then if you're prepared to deal with that, then I would say, should I do 12 now or 18 now? Okay, you know, maybe I'll just do 12 now, and then I'm willing to do more in the future. If you want to try and get a durable remission, if it were me, I'd be doing more now. So, you know, but that's my opinion. I mean, anyone else? Len, what are your thoughts?
Well, I've already expressed my thoughts. I have a similar case to you, Rich. Gleason 9 also. And I shouldn't be giving you advice to stay on ADT because I didn't. I went off.
How long? How long were you on?
Yeah, I've been off now for.
How long were you on for primary treatment?
Well,
First time.
I was on intermittent. So if I added up all the intermittents, it's about 20 months. But I was never on more than 15 months consecutive.
Okay, Len, your initial treatment, you got radiation and ADT?
I didn't even have radiation. I only had ADT for the first 2 years and 3 months.
Okay.
It was intermittent though. And then I had radiation.
Okay.
And yeah, after radiation, I was only on an additional 6 months. And then I've been on drug holiday for about 18 months now. But I don't have an undetectable PSA. My PSA is 0.6.
Okay. And as everybody here knows, we're all different.
Yeah.
We react differently. We're treated differently. Side effects are different. And the person that looks at me in the mirror is different. I don't have an answer. I have an answer, but it's not the right answer, but the doctor doesn't have the right one either, because neither one of us knows. As of right now, it'll be entertaining to see what he can present as a discussion point in his favor for 18. Our radiation oncologist notes indicate at least 12 months ADT. A couple of months before radiation, but at least a total of 12. Past that, all bets are off.
Well, okay. I mean, well, I hear you, but I just want to say all bets are off for you, but I think that there's good evidence out there that, and good clinical evidence out there that longer than 12 months makes sense. You may not accept it. That I agree. That I understand. You may not accept it, and everybody's different, and it's not true for everybody that it's going to make a difference, and you might be the unlucky one. But when they do the studies and they come up with the evidential recommendations, there's good evidence that longer than 12 months makes sense. The studies are there. You may not, you can find them and point holes in them, but the studies are there. I mean, yeah, we could argue that 18 is just as good as 36, and I did. But then you get somebody like Mac Roach, who's a real expert, and says, but that study was underpowered. It's not a reliable study. So he's He still goes back to the old study, which was radiation plus hormone therapy 4 versus 28, which he considers to be the most reliable study. But I don't want to beat a dead horse. At least you're going to give your doc the opportunity to tell you. Now, which doc is this? Is this a radiation oncologist you're going to see, or is this a GU med onc, or who are you seeing?
The one I'm seeing tomorrow is a urological oncologist. He's the guy that gives the shots. The radiation oncologist, my next appointment with him is February.
Yeah.
And he's the doc that wrote at least 12.
Yeah, well, again, I don't think it's the urologic oncologist's call. I think it's either the radiation oncologist's call or a GU med onc's call. So for me personally, I wouldn't put a lot of weight on what the urologic oncologist, what the surgeon says.
I just wanted to hear what he said.
Oh, yes, hear what he says, but I wouldn't put a lot of weight on it. The weight should be either with the radiation oncologist or better still, a GU med onc. But one or the other.
Hey, Jake.
Just saying.
Hey, Jake, did this conversation go about like we discussed?
Yeah, pretty much.
We talked about it.
But it's because we love you and we know what we do. And we don't want to see you have to be on this rubbish for the rest of your life. That's why.
You just missed the melodious baritone. That's all.
We would.
We do.
We would miss the melodious baritone, but the fact is that if we can get you a durable remission, it's less likely you're going to stay with us because after 3 these guys anyway. So our personal interest is get off after 12 months.
There you go. I appreciate your support.
Okay. Mike Stewart.
Yes, sir.
Are you still with us?
I'm still here.
Okay. All right. That's what we want to hear. Another Southern accent, a little bit further south than Virginia, North Carolina.
Yeah, not too far.
Maybe you just want to tell these guys quickly what your situation is, and I know you're going to be going to talk to your docs again pretty soon.
Well, actually, I was at Duke again on the 15th. Had a PET scan then. Results came back. It is in my lymph nodes now, but it's microscopic. It appears to be. I am going on, had my first Lupron shot at that time and doing well with that so far. No side effects whatsoever. Just kind of in that holding position, I guess. Now we're talking about doing 6 months and then doing our holiday for the next 12 months if PSA works out. I think he's talking about 0.2 would determine whether we continue on or stop for a year. So that's kind of in a nutshell is what's happened in the last month. Biggest thing though is PSA has continued to double. It's doubled 3 times this year. I'm now up to I think it's a 1.14, which started out in January as a 0.14.
Right. So, maybe Rich Jackson should go down to Duke and see Dr. Armstrong. He could get away with 6 months. What do you think, Glenn? Do you like that?
One that gives you what you want to hear.
That's right. Hey, what do you think, Jackson? How about it? Get on your bike, take a little ride down to Raleigh, Durham. He's quiet. Are you
The
still
problem
there?
I'd run into is I've already finished my 12. He'd want to give me another 6 because he'd want to start over. You'd still get your 18.
We're still going to do 18.
So there you go. I did my time.
A couple of things I'm very surprised about, Mike. One is that, and I think this was the case from what you wrote me, that they gave you the Lupron shot without giving you any bicalutamide first. Is that right?
That's correct.
Yeah. I just, at a place like Duke, I just don't get that, especially when they knew that there was possibility of metastasis. I mean, I just don't get it. And the other is that this 6 months initially, I mean, originally you had a radical prostatectomy, correct?
That's correct.
And then at some point, this was in 2011, and then, I beg your pardon?
Yeah, that's correct. Yes.
Right. And then was it 2014 you had radiation to the prostate bed?
That was in 2012, right after, I guess probably 6 months after the prostatectomy.
Okay, and that was, and you didn't do any hormone therapy with that, correct?
Correct.
Right. And then, and has there been no discussion with Armstrong about radiating your pelvic bed?
Yes, we
your pelvic girdle?
discussed that, but in his opinion, that it would do more damage than it would do good, considering where the location of the lymph nodes were.
But I personally would get a second opinion on that, only because it's not for sure that you have metastasis. That there, excuse me. We know that there is. Then we know there's something in the right iliac lymph node. Beyond that, we don't know where anything else is.
Right.
So, the side effects of pelvic radiation are pretty minimal. And again, it's the same story. If you've got a chance of nailing this disease right now, I would want to go full speed to try and nail it. You may not be successful, but what does that mean? Pelvic girdle radiation, 12 to 18 months of hormone therapy, that's what I would be doing. And I'm just surprised, and I'm concerned about Armstrong talking about 6 months, no radiation, not giving you bicalutamide before he gives you a Lupron shot. Yeah. I'd get a second opinion.
Well, after discussion I've heard tonight, that 18 months sounds more reasonable than 6.
Don't get it.
Mike, this is Peter.
Yes, sir.
Yeah, coincidentally, there's 2 of us on the call tonight who just had proton radiation for pelvic lymph node recurrence. I had mine. I just finished mine in California, and Les just finished his up in Minnesota. Yeah. So, I mean, you might want to explore that because it's a little more precise, in terms of radiation, in terms of targeting things in precarious areas. Well, how did you pick it up? Through a PSMA PET CT?
It was through the PET scan.
Yeah, that's how what happened with us. Anyway, just a thought, because it's not uncommon what you're going through.
The next thing I guess would be anyone have any recommendations? This is my second. This is already my second change, but so I'm ready for three if need be.
You know, I don't know how you would ever do it, if you could do it, because because I know Armstrong is in the same group, but I really would like you to get a consult with Dan George.
Georgia.
I mean, I have so much respect for him. He's so good. And if he came out with the same recommendations as Armstrong, you know, I would say you got a good answer. But I mean, I mean, I cannot tell you how dismaying it is to me that when a man has possible metastasis and they know he has possible metastasis, that they don't give you they don't give you a buffer, they don't give you a bicalutamide. I mean, if he would have given you a Firmagon shot, that's fine, but it's just Bush. It really is. I don't think there's anybody on this call who started off with a LHRH agonist who didn't get at least 2 or 3 weeks of bicalutamide first. Or if they did, they knew they were with the wrong doctor.
Okay.
I mean, it's so elementary. People just don't do that anymore. The last time I heard of that, I think, was at Kaiser. And you know, a close buddy of mine who had metastatic disease, and they did that to him. I think one other time I've heard of it since. It just doesn't happen. I mean, anyone else want to comment on that?
I agree with you, Rick. I've never heard of this before. And Mike, are you absolutely 100% sure that you got Lupron and not Firmagon or Degarelix?
No, it's in his notes that it says it's Lupron.
Okay. Yeah, that's
you
just
got the shot. You got the shot in your butt, or
yes.
or in your yeah.
It was in my butt.
Yeah.
It was 45 milligrams.
Yeah. Which is a 2-month shot. No, excuse me, it's longer.
6 months. 6 months.
6 months. 6 months, correct. 7.5 a month, 6-month shot. And again, you know, that's another thing. I mean, why go out all the way out to 6 months? I mean, let's see how you do with it. Go with a 90-day shot first of all. A lot of stuff that bothers me about Armstrong, but he's in the same group as, he's young though, isn't he? I looked him up one time. Isn't he relatively new?
Yes, he's probably early 40s.
Oh no. Well, look, if you could engineer a consult with Dan George, I'd do it. If you cannot, and you have to go elsewhere, I may be able to dig out a name for you at UNC. But usually, you know, if it's anybody in your area, we try and ship them to Dan George. Right. If you were willing to go beyond, then, you know, we would say try, I would probably say Hopkins or MD Anderson.
Okay.
And we can give you a name.
Hey, Mike, what was your testosterone level before they gave you the Lupron? Do you know?
No, it wasn't checked that I'm aware of. When I'm supposed to go back in May, they have me in for labs for it then, but it hasn't been done prior to that.
Yeah.
You have no reason to believe that it wasn't a normal T level.
You know, I don't know. That would be something. I've never had that done, so.
Yeah. And that's another thing, you know, but a lot of doctors don't do it, but we always say, get your testosterone measured. I mean, even now, how long is it since you had your, the shot? Is it a week?
2 weeks, the 15th of November.
Yeah.
So we're right at.
Yeah, I mean, I know I got mine measured about 2 or 3 days afterwards, but it's always good to measure so you have a baseline so that when you come off, you know where you want to get back to.
Right. Makes sense.
But yeah, I mean, I would probably suggest, MD Anderson from where you are, or Hopkins, as being the two best alternatives. And I can give you names. You know, if you decide you want to do that, I can give you names.
All right.
In both places, and see what and see what they say. But it's strange for Duke. It's really strange.
Well, I was thinking myself, we were extending it out further than the 3 months prior to that. So had a little bit of concern myself, you know, with time passing by.
Well, keep coming back. There's lots of good information on this call. Lots of opinions. You know.
But
anybody else want to say anything to Mike other than Len and Peter about this this early treatment?
It's Rich Jackson. I did Casodex bicalutamide 2 weeks before I got the 6-month Lupron shot.
Yeah.
And at the time, my urologist, that's all he did.
Yeah.
To get anything else, he had to order it in, and he was going to change to Firmagon.
Right. And I mean, I did. I'm sure. I think Len did. I mean, they just. The reason why, Mike, is because the way that the agonist works, it gives you a spike in testosterone over the first couple of weeks before it knocks it out. So, I mean, you could get a testosterone test right now. You'd probably show a pretty high level of testosterone, or higher than your normal level. And what happens is that the agonist stimulates the production of testosterone continuously to the point where the testes just shut off, or they say, we're working too hard, we're not going to do it. And and so the agonist keeps stimulating, and that's how it works. The antagonist is able to shut off the testosterone production without stimulating the testes. And the risk of having a lot of testosterone in your body, and I've actually known this happen to a couple of people, is that it can aggravate the cancer if it's in sensitive places, and it can cause, particularly if it's in the spine, it can cause a collapse of the spine. So they give you the bicalutamide, which is an anti-androgen, works in a completely different way as a buffer to protect you during that surge period.
Okay. Well, it sounds like I've got some homework to do again.
All right. Well, talk to us next week, or reach out and we'll support you. But there's a couple of things, and I really would like to. I'd really like you to get a better, to get another opinion at least on whether it makes sense to do pelvic girdle radiation right now.
Okay.
Okay.
All right. Well, thank you for the information.
Pleasure. I know we're running 15 minutes late. David Sanders, you came in late. Is there anything we can answer for you other than, I know we've had some discussion. You're muted right now, David. Are you still with us?
Rick, I've got to go.
Okay.
Yeah, Rick. No, I don't have anything else. I just came on board to get my weekly scare and get
Okay.
me motivated. So,
Okay.
thank you.
Okay. Stay cool. All right. Good night, everybody. And we'll see you next Tuesday, I think. Yeah. No, next month. Next Monday.
Good night, all.
Good night.
Good night.